The topic that I've been asked to talk about is aortic dissections. How many people here know about aortic dissections? Maybe some, but I'll tell you that there's never been an aortic dissection treated with a stent graft at Middlesex Hospital. Is that right, Bill? Okay. Except last week. We did the first one, right? And that person went home the next day. So it's very pertinent to what we're doing here in this community. These patients are generally being sent out, and delays matter for these patients. So aortic dissections are more common than aortic aneurysms, and you're quite familiar with treating aortic aneurysms, but you're less familiar with treating aortic dissections. So I want to tell you about aortic dissections. Aortic wall is composed of multiple layers, and you can see this nice schematic here on the left. Next slide. So a dissection is a tear in the aortic wall. And the tear generally occurs about 2/3 of the way through the wall. And you can see over here on this CAT scan, this is a dynamic CAT scan which is showing the movement of the aorta and the tear. And you can see the little line in the aorta, both in the upper aorta, which is the ascending aorta, and the descending aorta, which is down in the lower right. You can see that tear, and it's very dynamic. It's moving back and forth. And that tear can go on to rupture the aorta, which is the patient that we had last week had a rupture, right? That tear can go on to extend and shear off the side vessels like the superior mesenteric artery or the renal vessels, put them in dialysis, or give them ischemia to their intestines and ultimately die. Next slide. So if you look at the aorta, right, you think about an aortic dissection, this is really fascinating disease. So this is actually an MRI of my aorta, okay? And you can see the circle right there. And I don't have an aneurysm. Can you click on that, Paul? But what you, no, go back. Go back. Actually, move the mouse. Press it. What you can see is that the aorta is not just a static image, right? It's not just a picture that you see on the MRI. But this is really a moving, almost like living kind of organ. And it's that dynamic environment of the aorta which is the results in dissection. So that's my aorta pulsing, and I think it looks pretty good. Next slide. But it can go on to tear, and you can see this is an aorta, and you had seen this image before where a dissection occurred. That can go on, and the mortality of aortic dissections exceeds 50%. So over half the people that have an aortic dissection will ultimately die from that disease unless they're treated. Next slide. Right? But it's more than just a static image, right? So we started with a drawing. I showed you the drawing of the layers of the aorta. Well, it's more than that. It's a picture. I showed you a CAT scan, and I showed you an MRI, and the MRI is moving. But it's more than that because there's blood flowing through the aorta. And this MRI, which shows the velocity of blood, this is not my aorta, the velocity of blood shooting through there shows that there's all these interesting forces, and it's those interesting forces, this moving blood that jets into the side of the aorta, which causes that tear and a little hole in the aorta, which then extends that dissection and causes all these problems. So it's pretty simple. It's just a little hole usually. It's just a little hole. Next slide. So if you look at the picture on the left, you can see that there's a dissection with a line going down, and Paul's showing you the line, right? And what you need to do, so that the blood is now flowing into two places, the true lumen, where it should be going, and the false lumen, which is the area that's sort of dissected, right? Hence the term dissection. And so what you want to do is steer all the blood flow back into the true lumen. And one way you can do that is by placing a stent graft in the true lumen. And you can see I've done that over there on the right. You can see a stent graft. That's from one of our sponsors. And that's going right into the thoracic aorta. And it's blocking up the hole that causes a dissection and steering the blood into the true lumen. And that allows the blood to go into your intestines and your kidneys and down your legs. And for the most part, people do really well when you get this stent graft in the right place. All right, so that's important. When you look at this, the landmark that we always look at is the subclavian artery. Can you point that out on the left? So in all these images I'm going to show you, you can see that right there's the subclavian artery. That's the artery that goes to your left arm, the left subclavian. That's our landmark, and usually that's where these, we call them type B dissections. That's after the subclavian artery occur, very common, and that's what we use as a landmark. So we try to go from the subclavian artery down and channel blood into the true lumen. Next slide. So that seems simple. We should just do that on everybody, maybe even prophylactically. Maybe we could get Dr. Gagne to come in. I'll just put a stent in him because he might get a dissection. But that's not obviously the case because these are complicated problems and they do have complications. So you have to be thoughtful about it. And this is one of my complications. This is when I was in the Netherlands. I did a lot of work in there in endovascular treatment. And I placed this stent graft, and you can see there's a sort of an aneurysm. It's not really a dissection, but a rupture of the aorta down at the bottom, that little thing. Can you point that out, Paul? That little thing there. This person was in a car accident. And I placed a stent graft over it to cover that hole in the aorta, and you can see the whole stent graft collapsed, right? Ultimately, this patient had a long, complicated course. They required open surgery. He was a lawyer, too, and required a long, complicated open surgery. Ultimately, he did fine, but you can see this is not without problems. So we want to try to be thoughtful in what we do. Next slide. So let's back up a little bit. Let's just talk about dissections. There's a lot of subcategories of dissections. So let's just talk about chronic dissections. So these are dissections that happen that are more than 14 days old. So they've happened. They're usually what we call type B. That means they go from the left subclavian down. So they're not near your heart. They're past your heart, right? And this problem is potentially fatal. Their mortality is greater than 50%. So it's a big problem. All right, so that's a dissection. So what you should do about them is controversial. Historically, and I can tell you, historically goes until last week at Middlesex Hospital, they were treated with medical management alone. So they were treated with beta blockers, anti-impulse therapy, lower their blood pressure, try to, you know that image I showed you of the blood wishing through the aorta? Try to slow that down and calm it down, right? Well, that works, but over the last couple of decades, we've been treating these patients by putting stent grafts in them to seal up that hole, to block up that hole, to rechannel the blood into the true lumen, and we've been doing that with pretty good short-term results, and they've done reasonably well. Next slide. You'd think that if we're doing this, there must be a lot of data to support it. Well, actually, there's almost none. There's one randomized controlled trial in the literature. It's called the INSTEAD trial. Can you hit the button? And basically, it compared medical management versus stent grafts. And hit the button again. And if you go down, and I just put in quotes, at 2 years, there's no difference in rupture, survival, or reintervention if you get medicine or you get a stent. So a lot of people were saying, okay, we shouldn't stent these people because there's no difference. Let's just give them medicine. It's cheaper, it's easier, less, you know, they have the same outcomes. Next slide. So, but I kind of felt, and some of my colleagues kind of felt, that it's more than just death that matters. It's also quality of life. So you can be alive in a nursing home, not able to eat, not able to breathe, not able to talk to your people, your friends, and not able to walk. And, well, you're not dead, but you really don't have a very good quality of life. So I think that what matters is your quality of life. And so this is a study that our group did. I was a lead author on this, and we published it in the Journal of Endovascular Therapy, where we looked at medical management versus stent graft on quality of life. We specifically looked at things like stroke, dialysis, being paralyzed, having a rupture later on, needing secondary interventions. And we determined, and we tried to determine, is a stent better than medicine if you're going to look at your quality of life? Next. So we basically look what matters in all patients that get surgery, and especially vascular patients. How old you are, whether you're a man and a woman. Women always do worse in vascular surgery. That's a proven fact. How big your aorta is when you start. Is it really aneurysmal? And if you're a high-risk or low-risk patient, meaning is your heart working really well? Do you have pneumonia? And we all know who those high-risk patients are and who those low-risk patients are. And next slide. We used a Markov analysis, next slide, to kind of model this to determine, and this is well established in the literature, what is the best outcome. Next slide. So with this model, you can plug in these different variables, like, Paul, how old are you? So Paul's a 20-year-old male, right? That may come in with a dissection with a 5-centimeter aneurysm. He's a good surgical risk, and we can plug it into this model, and it will tell us what he should get. Should he get a stent? Should he get medicine? Or should he get open surgery? Next slide. And we know, and let's just go through all these. We know for open repair how successful it is, what your mortality rate is, what your stroke rate is, what percentage of people go into renal failure. We know all this from the literature. Next slide. We also know this for endovascular repair. If you get a stent graft, we know who's going to die, who's going to get paralyzed, who's going to have a stroke, right? We know all these things from the literature, and we can plug this into the model. Next slide. And then there's actually, believe it or not, published quality of life variables out there that have been validated. Next slide. So these are your quality of life. So if you have a good recovery, your quality of life is 0.95. Like 1 would be perfect, but you had a little surgery, so it's like 0.95. If you die, your quality of life is 0. Okay? And there's some variables in between. You can actually have a negative quality of life. Okay? If you have, you know, a really bad complication, it can be less than 0, so worse than dead. Next slide. So we can use these quality of lives, put it in that model with the known statistical variables, and create a model and determine what the best treatment is for various patients. Next slide. Next slide. And then you can sort of change these variables over time. And I'm not going to go into the statistics here, but just to say that you can say, okay, well, this is what you should do for a 60-year-old. What about a 65-year-old? What about a 70-year-old? And so on and so forth, in whatever age you decide. Next slide. And you can see at certain areas it may change. Maybe when you're really young and you're really healthy and you have a big aorta, you should get an open surgery. It's durable, it lasts forever. Maybe when you're old, maybe you're 99 and you're very frail, maybe you should get nothing. Maybe that's the best option. And then somewhere in the middle, maybe you should get a stent graft. Okay, next slide. And you can do that, keep going through all this. You can do that for age, you can do that for gender, you can keep going all through all this. You can do it for all of these things. You can create a chart that kind of looks like this. And we did this, right? So you can see there's a whole bunch of variables on the side. How big your aorta is, and just skip to the next slide. And this is sort of like a blown up version. You can plug in there how old you are, 50, 55, 60, whether you're a man, whether you're a woman, whether your aorta is small, whether it's big, whatever size it is, and go and find out what your optimal treatment is based on these modeling. Next slide. So, and part of it's cut off, but you can see there's a very big chart, right, about what you should get. And what I can tell you is there's a mix of what you should get. The blue is you should get an endovascular stent graft. The red is maybe you should get an open repair. The yellow is maybe you should just get medicine, okay? But the simple point is, currently in this community, everybody is getting the yellow, right? And the yellow is not necessarily the treatment that everybody should get, right? There's other treatment options, and the TVAR, and I can tell you that now we can certainly offer the stent, the medicine, or even the open repair if needed. So that is the opinion of our publication, right? That's sort of the opinion of the general community. And go to the next slide. So if you look at the conclusion of this talk, is there's no one-size-fits-all treatment for these dissections. It's not everyone should get medicine, everyone should get open surgery, everyone should get a stent. It needs to be individualized. And it depends on many factors like age, how big your aorta is, how frail you are. For the most part, if you look at the general population, most people should probably get a stent. That's what we believe. And of all the variables, age is the most important. So this model can be used as a guide on what to do. Obviously, everybody's individualized. But generally speaking, these options should be considered for our patients that come into our community. Next slide. So keep going. And one more. There. So if you remember, early on, I told you there was only one randomized trial that compared medicine to a stent. And I put in quotes, there was no difference at 2 years between a stent or medicine. Well, that has now been updated with 5-year data. And when you carry this out, it's called the INSTEAD XL. It's actually shown that the outcomes are better in the patients that got stented than patients that got medical therapy for all comers. So that also corroborates our modeling paper, and that patients that are good candidates should be considered for endovascular stent grafting. I'd like to finish and tell you, go back. I'd like to tell you, go to that black slide. So this is actually important because you're looking at a black slide, but what the point is that all of this has happened. You know, vascular surgery has undergone a revolution, and tonight everything you're going to hear about is image-guided vascular surgery, right? And that's changed. I would say 70% of now a modern vascular surgery practice is endovascular and image-guided. And I think this video just highlights that surgery in general, just click on that thing, surgery in general has always been dependent on imaging. And this is just 30 seconds. I'm sorry you can't hear the sound, but it's in Italian. Next slide. So image has always been important. So thanks again for coming. Thanks for the opportunity.